study clearly showed that there was about a 40 to 45% abstinence rate if they attended AA, compared to only about 20%. So twice as many people remain abstinent if they attended AA. Now, you always have to be careful when you're interpreting studies like this, because we're looking at a correlation, right? Not that one caused the other necessarily. It's a suggestion, which then leads to further studies looking at causality. This study looked at the number of meetings one attended and how it related to abstinence. So in a year, if somebody attended at least 50 meetings, they were 60% likely to be abstinent. As the number of meetings attended increased, likelihood of being abstinent increased. What is this genospirituality? Well, a whole new area of research looking at genetics and this thing we refer to as spirituality. What is it? One of the common barriers to becoming involved in a 12-step program is the idea of God. And so patients will say that they don't believe in God, so AA doesn't apply to them. Well, it's not really God. God might be one's formulation of spirituality, but overall it's much more helpful to think of it in terms of spirituality rather than religion. Now, of course, God doesn't necessarily have anything to do with religion, right? Religion being man-made and the whole bit. We won't get controversial here. But I want to just examine a couple things with you. Is spirituality an intrinsic biological trait? Religion, on the other hand, is transmitted culturally. What do we mean by spirituality? This feel-good sensation, a feeling of connection with something greater than oneself. Protective against substance use. High church attendance has been shown to reflect genetically influenced temperamental factors creating this protection. You have been part of a group at some point in your life. The group is greater than yourself. Spirituality simply refers to feeling connected to the group. That's all. It's really that simple. Experiencing that is correlated with being healthier. And certainly, it's the lack of that that results or has resulted in addiction. That person with addiction has no connection with anyone, let alone a group. There's only one focus, the substance. This is gone. The studies are showing us that getting this back markedly increases the likelihood of remaining abstinent. Religion, on the other hand, is an example of spirituality. People worshiping together in church, for example, feel part of a group. They're experiencing the spirituality. It happens to be in a church, doesn't have to be. Here it's a unified system of beliefs and practices, and it unites the society into a single moral community. Social bonding, feeling that connection to other, lowers the rate of substance use. And of course, the 12-step membership is built around social bonding. So maybe this is the connection, the connection between the 12-step membership and spirituality. Feeling part of a group. I'm around a lot of other people who are like me, experiencing some of the same struggles as I am, who identify with me, who can help me, they're providing support to me, et cetera, et cetera. Strengthening those bonds. This is a particular study done by the National Institute on Drug Abuse, referred to as DATOS, looked at relapse as a function of spirituality. The degree of spirituality, okay, you're suffering from addiction. How likely are you to relapse? What do we look at? Well, let's look at, in this study, how much spirituality do you have? That's going to help us predict whether you have a 10% risk of relapse or 100% risk of relapse. That's essentially what this was looking at. So, it was a prospective study going forward, funded by the U.S. Department of Health and Human Services and National Institute of Health and National Institute on Drug Abuse. No small organizations funding a study like this. Right? I would think that that would surprise a lot of you. It was designed to measure outcomes of adult drug use treatment in 11 different cities during this period, 1991 to 1993. 10,000 subjects who were interviewed at 1 month in the study, 3 months, 6 months, and 12 months. They looked at the 12-month relapse rate and spirituality data obtained for 3,000 of them. In this sample, 65% male, 47% African American. The most common substance at this time was crack cocaine. This is how they chose to look at spirituality in this population. This is one way of looking at spirituality, right? They were focusing on religion in this particular population. They looked at the strength of the religious beliefs, the frequency of attending religious services, the frequency of reading religious books, the frequency of watching religious programs, and the frequency of meditation or prayer. So the blue shows that these particular things were not important to the individual. The rust color shows that they were very important to the individual. So the strength of their beliefs. The individual who felt that that wasn't very important had lower remission rates than the person who thought it was very important. And of course, that carried through across the board. And although in some cases it doesn't seem to be a significant difference, it turned out to be statistically significant. So it matters. Not a powerful effect, but it matters. Remission correlates with spirituality, was concluded. Better outcomes with the sponsor. Encouraging religious participation if someone is already religious is helpful. Spirituality helps protect against relapse. This reward deficiency syndrome leads to deviance from I'm going to skip over that in the interest of time, but there's some evidence now. I mentioned it earlier when I showed you the dopamine and the receptors, that in some people who are more prone to developing addiction, they're not being rewarded to the same degree as the rest of us by natural rewards. So before they even become exposed to a substance, you choose your favorite food and you eat it and you experience pleasure in eating that favorite food. They choose their favorite food, they eat it, they experience only minimal pleasure, not the same degree as you. If you look at their nucleus accumbens, they don't have the same number of dopamine receptors, and the ones that they have are not working in the same healthy way. Reward deficiency syndrome. Born with that vulnerability. Another study looking at the molecular neurobiology of the 12 steps. Molecular neurobiology. I've taught you a lot about that neuron, its receptors, the axon, all of this activity that's occurring. Could there really be a connection to what's going on in that neuron and the 12-step program? Fascinating, right? All new research. I'm only going to give you an example of this. I'm not going to go through all 12 steps. So step 1. Actually, let's go to step 4, since that was the answer to an earlier question. Made a searching and fearless moral inventory of ourselves. So this is a time when the individual works with the sponsor and is guided through this moral inventory. How have my actions affected those around me? It can be positive and negative, but let's focus on all the negatives. Very, very difficult for that individual to do. And by the way, this is the most common time for an individual to relapse while working on step 4. If they're working on it properly, very, very powerful. His or her own evaluation of self and a list of resentments, what the RDS has driven the individual to do, that reward deficiency syndrome. How has my illness driven my actions, and how have those actions affected others? It turns out that there are genetics beginning to play a role in determining one's likelihood of being able to even identify these kinds of things. Let me introduce the concept of empathy. I can put myself in your shoes and imagine what you're feeling. So I can provide support to you, understanding. That's lacking in the person with too much narcissism. It's completely gone in the person with an antisocial personality. We'll talk about in the next lecture. There's a particular substance that actually increases empathy. We say that it's empathogenic or empathomimetic, increases empathy. Anybody know what it is? You'll all recognize it. Ecstasy. Ecstasy affects the brain in such a way that it increases empathy. There's another hormone that tends to increase empathy. And for those of you who have given birth, moms, you've all experienced elevations of this hormone at birth. And it's called oxytocin. The bonding hormone brings you closer to your infant. There are pharmaceutical companies working with these molecules to try to create a medicine that we can use to increase empathy. All about empathy. So you can see, if you have a gene that leads to an abnormal oxytocin molecule, for example, maybe you're not going to experience empathy as easily. So that gene is kind of affecting how you're affected by the 12 steps. You begin to see the connection. Molecular biology of the 12-step program. It's all in its infancy. Lots and lots of, now, we know the 12-step program works. But in the medical community, we're scientists, right? We want to know why it works. What's the mechanism of action? It's not enough to know that a medicine treats an illness. We want to know exactly how it treats that illness. What does it do to that particular tissue of the body that brings about change? That's what's going on right now with regard to the 12-step program. All right, I'm going to jump ahead a little. I know it's late. Covered a lot. Okay, recovery is a process. It takes time, it takes patience, it takes everything you got. There's the healthy brain, remember, over on the left, showing activity down deep. That person who had been using methamphetamine 1 month after coming in for treatment, 14 months later. 14 months. Look, you're all familiar with 28-day programs, 30-day programs. This person went to a 30-day program. Now he's discharged, ready to go back to work, right? How silly. How silly. 1 month program. You going to hire that person? Same type of thing. Okay. We distinguish between response, remission, and recovery. Response is improvement. You were this sick, now you're this sick. You're responding to treatment. Remission is the absence of symptoms. That doesn't mean you're healthy. It means you don't have symptoms. There's a difference, right? Recovery is a much more complex process. That's the goal for every one of our patients, not response or remission. Oh, by the way, speaking of that, we used to practice psychiatry such that in treating major depressive disorder, we were satisfied with getting the individual to respond. That meant a marked decrease in the intensity of symptoms. Great, you're better. Have a nice life. And then research showed that that wasn't good enough. Those people with even mild symptoms, we can't accept that because they are at high risk of developing relapse. That is, going back into the severe symptoms. In fact, we got to treat them aggressively enough to get them into remission, the absence of symptoms. It's very different. So how do we define recovery? The experience, which is a process and a sustained status through which individuals, families, and communities impacted by severe alcohol and other drug problems utilize internal and external resources to voluntarily resolve these problems, heal the wounds inflicted by these problems, actively manage their continued vulnerability to such problems, and develop a healthy, productive, and meaningful life. You see, it's a lot more complex than just getting rid of symptoms. It's now addressing how everything that's important to them and everybody who's important to them has been affected by the illness and working on repairing that, repairing the relationships, repairing the lives that have been affected by the illness itself. It's a process that involves you notice. What are some of the elements of recovery? I'll just cover a couple of them. Honesty, being able to enjoy life without substances, handling negative feelings without running to substances, being able to deal with situations that used to stump the person, striving to be consistent with beliefs and values, having values, getting along with family, trying to live in a place that's not overrun with alcohol or drugs. The enriched recovery includes a process of growth and development, taking responsibility for oneself, living a life that contributes to society. The spirituality of recovery, being grateful, giving back, helping other people, appreciating that I am part of the universe, something bigger than myself, becoming more open-minded. Love and work are the cornerstones of our humanness. Please have a seat. Work. So we've come to appreciate that part of recovery, as you just heard me read, involves taking responsibility for oneself and becoming independent and contributing to society, not exploiting others, not being a pariah, not being a leech, right? Not maintaining their pathologic dependence on you. All of the major psychiatric syndromes that I'm talking about today generally have their onset between mid to late adolescence and mid to late 20s. That developmental time period. That person born with some type of genetic vulnerability, perhaps experiencing some type of adverse childhood, not necessarily, then is on a developmental trajectory so that he's going to land somewhere in adulthood with an illness. The early prodromal symptoms, right? Those are the subtle ones that you're not really recognizing, are beginning mid-adolescence. And then you might see the full-blown disease in late adolescence. It might be a psychosis, a mania, a major depressive disorder, addiction. What's supposed to happen in the healthy state, which happened with most of you, I imagine, is that, all that mild chaos that occurs during adolescence kind of begins to settle down as we're gradually leaving the nest, right? Possibly going off to college or vocational school, getting out of your home, getting a job, learning how to become independent, responsible adults. That's a complex developmental event, actually, occurring all over those years. The psychiatric illnesses stop that process in its tracks. Development is no longer occurring. That dependence that was completely healthy in childhood and early to mid-adolescence is now continuing when it shouldn't be. Now it's pathologic dependence. It's a sick dependence that without even realizing it, you help to maintain. You have to take care of your son or daughter, is what you feel. I said to Evan today, your mother does not believe at 21 that you can actually go out in the world and become independent. She has to take care of you. What do you think about that? Now, he's still ambivalent because his mommy takes care of him, right? She was giving him money to go buy his marijuana. Who wouldn't want that in active addiction? But at the same time, we're getting to him. So he says, yeah, but I have to learn how to take care of myself. I have to tell her she can't do that anymore. She wants to maintain that pathologic dependence. That will keep him sick if it doesn't kill him. So the treatment involves getting back on track, the healthy trajectory, right? We want him to become healthy, independent, responsible, contributing to society, like the rest of us. Yes, please.
So say that development didn't happen in the 20s or the 30s or the 40s or the 50s. Can you grow through that even in your later life? Or is it too late because your pathways are just burned and,
It's a great question. What we see is that it's more difficult as time goes on, but not impossible. We have someone who's 57 in our program right now, and it's it's been quite a challenge. We haven't given up, and we still work hard, but it's been a challenge. So that's why we needed to introduce vocational services. Getting our patients, for those of you who don't know, the highest level of care we have is one step down from a locked inpatient unit, and that is residential treatment. So it's 24-hour medical supervision. They're sleeping on the 4th floor of our facility. They're getting treatment with the rest of us on the 2nd floor during the day. We cater their meals. We tell them when to get up, when they can go outside for a break, when they have to take a shower, when they have to wash their clothes. We tell them everything. They cannot make a choice. Why? The person who has a heart attack must lie in bed to recover. You can't let that heart do any more work than it absolutely has to do. Walking across the room to the bathroom is work, stressing the heart. It's not going to recover. All of these psychiatric illnesses affect the brain in such a way that when they first come into treatment, we need to take the stress away. We can't let that brain function any more than it absolutely must. Making a choice, making any kind of decision is extremely stressful for the brain. We prevent that from happening. We'll make all the choices. Of course, they don't like that. We determine when they can talk to you. You don't like that, they don't like that. But we know it works. As they begin to respond to treatment, we gradually drop them down. We're decreasing intensity of treatment, starting to see how the brain can begin to function in a healthier way. So we drop them from residential to PHP, partial hospital program. 7 hours a day. We then move them over to the PHP apartments while they're attending PHP on a daily basis. They're living in the apartments, 2 bedrooms, bathroom, kitchen, living room. Now they have to learn how to get along with each other. They're taken over to Walmart with a food card. They have to plan their meals for the week because they only get to go once a week. They're expected to prepare their meals. I asked them what they made for dinner last night. Gives me a lot of information. They have to share the bathroom. They have to be up on time. They have to take medicines. They're transported over to treatment where they are all day. They go back. They have a 12-step meeting. They have dinner. Time to socialize. We watch all of that. We see the choices they're making. We see how that brain is working. Is it responding to treatment? Can they tolerate the less structure by moving into that apartment? As they do, we drop them once again, intensive outpatient. Actually, even move their apartment. We have transitional living, where they're learning to be independent, responsible adults. IOP, 3 hours of treatment a day. But in the afternoon, after IOP, they're expected to go out and look for a job. That's where we are here, looking for a job. Will work as food. Due to his grammar mistake, Wilbur found a position. It just wasn't the one he wanted. I said to Evan, he was a focus today, that's why I keep coming back to him. He's in IOP now. I said, have you gotten a job? He said, no. He said, but I'm waiting for, I forget which one it was, to hire me. I said, oh, great. You applied? He said, no. I said, how do you expect to get the job without applying? And he looked at me with this quizzical look and he said, good point. Now, they're looking for jobs and they're walking to the bus stop because we don't let you buy a car, even though you would buy the Mercedes. They have to take the bus. It's humbling. Oh, by the way, what's the best way? No, I'll ask them. I won't ask you. What is the best way to rapidly increase? Now, let me ask that a different way. What's the best way to rapidly decrease narcissism? I can't hear any of you. What was that word? Humility. Absolutely. So effective. Help the individual to develop humility. One of the ways, of course we have a lot of ways of doing that, but one of the ways we do that is we insist that the patient ride the bus. Get a bus pass. Ride the bus. They quickly learn to appreciate the things that you have given them, that they've learned to take for granted. But at the bus stop, at least here in South Florida, it's a very common occurrence to be offered drugs, particularly marijuana, often other things, or even on the bus. We recognize that, but we have learned from their experience that it is much better to take the risk in order to help them get well than to completely protect them from it. We protected them from it early on. Now we have decided as a treatment team and often the rest of the community have decided that this patient is ready to be exposed to that risk. Let's see what happens. And then that's what we talk about in terms of triggers. People, places, and things resulting in craving. Craving, not use. Right? The craving comes first. What do they do with the craving? The healthy thing to do is to tell somebody right away. Do they tell the sponsor? Do they run back and tell the staff? Do they come into community and talk about it? Do they tell their roommate? And if not, why not? And so we're looking at that all the time in order to strengthen their ability to tolerate craving, which will occur for some length of time, which is different for different individuals. And I'll come back to that in a minute.
You've often referred to sponsor. I'm assuming that's someone other than the therapist. Is that a different patient? Who is a sponsor?
Oh, great. Thank you so much. James, would you do that? Answer that question while I get a drink of water?
So a sponsor is someone that is in AA or in NA or any of the fellowships that patients are allowed to go to. And even in fact, if they went to NAMI, they could get a sponsor through NAMI as well, actually a peer. So it's someone that's been through the program, is sober for X number of years. Usually they recommend if you're going to sponsor somebody, you get 1 year clean, and you've worked your steps. So just someone that's walked the walk before and is currently living a spiritual life, doing the steps, and they take that individual, their spot C, through the steps, and they guide them through recovery.
So someone at
outside.
Someone at IOP level has a sponsor.
Yes, and it's actually a requirement to move to the level system.
Yeah, you just mentioned the level system. So when they move into transitional living and they're attending IOP, they go through this 4-part level system. Starting in level 1, you're going to hear all the details about that tomorrow, but I'm just giving you an overview. There's certain requirements that they have to meet, like getting a job, getting a sponsor, and other such, to move to level 2, then requirements to move to level 3. Level 3 is the first time that they are able to have a cell phone on them if they can afford to buy it themselves. They're not allowed to be part of your plan. We don't want that umbilical cord still in place. Right? And then finally at level 4, that's the very first time that they can actually hold on to their own money. Up until then, we control it. Money is a trigger. Money is a pile of cocaine. I've showed you enough scans. Now I'm going to stimulate your nucleus accumbens. Okay. Relapse. It does happen, right? Sometimes somebody with hypertension relapses, somebody with diabetes relapses, somebody with COPD relapses. Guess what? Somebody with addiction can relapse. Is it preventable? People who use opiates have a 91% relapse rate. I talked to you about that, 90% relapse. That's not on buprenorphine, by the way. Methamphetamine, 90%, alcohol, 75%, benzos, 51%, cocaine, 41%. I'm going to skip this video. She just talks about her relapse. It's very powerful, but I know you're getting tired. I talked about the chronic illness relapse rates. Asthma relapse, 50 to 70%, even more so than drug addiction. Relapse does not mean failure. Chronic diseases require maintenance treatment. I'm going to read this to you because I think it's a very powerful message. Dr. McClellan was the so-called drug czar under President Obama, first term. He said, suppose I said to you something really shocking, that diabetics or asthmatics or hypertensives had been in treatment 5 times in their lives. Let's say he's 40 years old and he'd been in 5 times in his life. The first thing a responsible physician would say, what do you mean, been in treatment? Why was he ever out of treatment? He should have been continually in treatment. He should have been continually monitored. We would have expected some ebbs and flows here, and we should have adjusted accordingly. It would be malpractice to try to take a diabetic and say, well, we're going to try to get you off your insulin, and then you'll be cured. It's just not done. In fact, if you had to take your pick between all the chronic disorders to get, which should you pick? I'd pick cocaine addiction, because that one at least you'll find with sustained treatment and involvement, you will have very little impediment for the rest of your life, and that's not the case with these disorders. You show me a chronic medical disorder, anyone, and I'll show you the need for behavioral change if the treatment is to work. If people don't change their behavior in addition to taking their insulin, they don't change their behavior in addition to taking their hypertensive medication, if they don't, in addition to taking methadone or antabuse or naltrexone, you will see relapse. So behavioral change is necessary, and behavioral change needs to be practiced and needs to be supported. That's amongst the many wonderful contributions of AA, NA, CA, and other support groups. Families, Al-Anon, all these things help a person who wants to change his behavior change. The idea of going into, quote, treatment, close quote, for this specified number of days, and now suddenly you're cured, it's naive. Addiction is a chronic illness. The person with addiction needs to be followed forever. Right? I see my doctor twice a year to check my hypertension. He hasn't changed a thing in the last 5 years. I don't say I'm cured. The person with addiction needs to get a physical exam every year, just like the rest of us. Maybe he should check in twice a year with his family practitioner. Look, this is what's going on in my recovery. This is what I'm doing with my sponsor. This is what I'm doing with my sponsees. This is how I'm contributing to society. looking for all of that evidence of healthy brain function. If he had a seizure disorder, he'd be seeing his neurologist regularly, even if he hasn't had a seizure in 10 years. Addiction should be no different. This is what we know today in medicine about the disease of addiction. I went to my HMO doctor today. I think your doctor is an HMO, but Frank thinks he's straight. All right, any questions before we stop this lecture? Yes.
So, someone that has been sober for 20 years, 10 years, and then they relapse, after all those years, is it the same as just somebody relapsing after a month? After 20 years, 10 years, 12 years, what's happening there? What's the brain doing there that they just fall back into after that many years?
It's not the same across the board for everybody in that situation. So you look very specifically at that person and try to identify what made him vulnerable, particularly vulnerable, at that moment that the idea was developed about relapsing, and then the craving came about, and what action that person then took. So, without revealing anything about that individual, I can give you an example. It's not enough to just stop using. I hope I've helped you to appreciate that. You got to get that brain healthy. It's very common for, everybody with addiction to have their narcissism severely magnified. Now suppose, and you're going to learn in the next lecture about a narcissistic personality disorder. Suppose the person had already developed that prior to the onset of addiction. That narcissism is powerfully magnified in the midst of addiction. So then the person stops using and is abstinent for 20 years. Well, what's going on with the narcissistic personality disorder? That's a severe illness. That's still there. Sure, people live with it miserably. On the surface, they might seem to be happy, but they're miserable. That narcissism is awful for them because it creates a tremendous, I'll talk about it in the next lecture, but it creates a tremendous emptiness. Everything's a facade. That creates the chronic vulnerability to relapse. You can predict it's going to happen. Now, why it happens at that particular moment, you look more closely about what's going on. Was there what we call a narcissistic injury? Was that person slighted somehow by the slightest little thing? That just tipped him over the edge. And he could not tolerate even worse of a sense of emptiness. Said, cover it up immediately, numb himself, use a substance. Because the brain never forgets the experience of substances on that nucleus accumbens. It will always remember, it knows how to get an emergency amount of dopamine secreted in that nucleus accumbens, right? Ingest that substance. That will always be in the long-term memory. Good question.
Seems like schizophrenia, though, is a different ballgame, which can create an addiction.
We don't have evidence that schizophrenia creates an addiction. There's lots of research being done in this area. There may be parallel processes in the brain that make the individual vulnerable to developing schizophrenia and addiction. Another way of looking at that is, with the concentration of THC increasing dramatically in cannabis over the last 10 to 15 years. We see more patients presenting with psychosis than we did in the past, and that's being documented in various studies around the country. Now, the question early on was, this person who's presenting with psychosis and has been smoking marijuana on a regular basis, is this cannabis-induced psychosis? Or is this a person who, until now, had a genetic vulnerability to developing schizophrenia, which was covered up until exposed to the high concentration of THC, which now revealed the presence of the underlying schizophrenia. And so we see the psychosis. I think studies are pointing more toward that hypothesis. So the reason that becomes such an issue is when somebody comes in with a substance-induced psychosis, yeah, we treat them with an antipsychotic, but how long should they stay on it? If it was substance-induced, well, if we stay away from the substance, the psychosis is going to naturally resolve. The only reason we give the antipsychotic is to get them well faster. If we wait, it might take a few weeks. If we introduce the medicine, it might take a few days. But what if this person really has schizophrenia and not a substance-induced psychosis? Then that person needs to stay on the antipsychotic forever. So how do we tease it apart? Well, the only way we know how to do it is to take the risk of taking them off that antipsychotic early, assuming it's substance-induced, and watch them. What we see more often than not is that person now presents a relapse of psychosis, showing us, uh-oh, it was schizophrenia. That's more often the case now. Something else that has been looked at and continues to be researched, I just lost my train of thought. Sorry, maybe it'll come back to me. Any other questions? Yes.
I've been unfortunately perhaps watching too much of the PBS special, The Brain, but there was mention of transcranial magnetic stimulation earlier, and since there are conditions in which it can affect an incredible cure quickly, is there anything being done with the addictive behaviors and things? The thing I saw last night, they had the hat, they had the TMS magnetic thing on. They set a page in front of him and 2 buttons. And if it shows red on the screen, he's going to push the right-hand button. And he said he was going to push the right-hand button. And they show the red, he pushes the right-hand button. They give him a shot of TMS, and they show the red, and he pushes the left button. And when they asked him, they said, "Oh, that was the button I was going to push." The concept was it actually changed his mind. He made a different decision after receiving the electromagnetic stimulation on the instant of it. One button, other button. It was, it was impactful. And could you address that a little bit? Are they doing anything with this? I know you guys are. Sort of a broad question.
No, it's a good question, but there are many ways of stimulating the brain. So we use TMS, transcranial magnetic stimulation, as one particular method that's been shown to be effective for treating major depression that doesn't respond completely to antidepressant medicines. That's the only FDA approval for it so far. There'll be more in the future depending on what the studies show. And there are lots of studies looking at its use in other psychiatric syndromes. There have been a number of studies that have been completed using TMS to decrease craving in addiction. So we have recruited a number of your loved ones to participate in a study. and they've learned about it and have consented to it, it's generally safe, and have undergone treatments. How many subjects do we have now? 9. So we've completed treatment in 9, and we have identified the intensity of their craving before the first treatment, and then throughout the treatment, and then at the end of treatment. And we have these beautiful graphs showing a marked reduction in craving across the board in all 9 of them. Which is consistent with what the studies have shown that have already been done. They do a lot of those studies at Duke University. But it's exciting, but a lot of the parameters are just being worked out because we don't know the optimal number of treatments, we don't know the optimal intensity of the magnetic stimulation, that kind of thing. So it'll be fine-tuned over time, but it's very exciting just to see significant improvement in craving already.
And I know the second half of my question, and that was, you were talking about the dendrites and the ones that only have 3,000 versus 10,000. And my understanding of the concept of that is that it's giving the magnetic, thus creating electrical currents, and it's increasing blood flow. It's doing all the things that would build pathways, like building a new superhighway where you had an old country road before, and quickly. So, does that actually, is that the point of mechanism, that it increasing the dendrites so that the reception is, retuned?
I love that analogy. Having grown up in the country, yes, it improves communication. Yes, the studies, to my knowledge, haven't been done yet, but it makes perfect sense that that's what you would predict is likely happening. Anything happening to improve a function, cognitive or emotional function of the brain, must involve improving the communication from one neuron to the next. Has to. Great question. Yeah.
When they use the TMS for depression, the FDA approved treatment, and then they're looking at it for cravings or other symptoms, are they targeting the same area, or is it just the same tool but different area of the brain being targeted?
Boy, these are all sophisticated questions. It's a pleasure. Some studies yes, some studies no. So, for example, we use a protocol that does target the same area. Remember the working memory? It's observed by the dorsolateral prefrontal cortex. So the depression studies showed that that particular area for placement of the magnet was the ideal location to stimulate in order to bring about the decrease in depression. Now the thinking is that the neurons in that cortex stretch their axons down deep into various areas, but one of the places is right beneath the anterior cingulate. It's the subgenual anterior cingulate cortex. It turns out that in a severe depression, that very tiny area of the brain is overactive. Research has shown that if you stick a probe through the skull, through the brain, all the way down to that particular part, and you stimulate it, you improve the depression. Didn't make sense that stimulating the hyperactive area was going to improve it, right? But it turned out the early researchers were wrong. They thought they were stimulating that specific area. In fact, they were stimulating the surrounding area, which would put the brakes on the hyperactive area. It's fascinating. Deep brain stimulation. It's an FDA-approved treatment for very severe treatment-resistant depression. Well, since we know that, the probe right at the site leads to improvement. The thinking is that by stimulating these upper neurons, which are sending axons to that same site, that's what we're doing, essentially providing deep brain stimulation with the magnet. Now to decrease craving, the thinking is that those neurons stretch even further to the nucleus accumbens. The company that makes the machine is actually creating magnets that have been shown to reach deeper parts of the brain specifically for that purpose, to be able to stimulate the nucleus accumbens and markedly decrease craving. We're all very hopeful that we're going to be able to use that. Actually, it would be great to just integrate it into our program as a routine procedure for everyone experiencing significant craving on admission. Because remember, keeping them in treatment is so difficult. That guy who came in on Sunday left on Monday. The craving was overwhelming.
So if you are treating someone with TMS for depression, that may, exact same treatment,
Yeah.
may also relieve the cravings if they're having those too.
Yeah, and in fact, we measure that. James and I realized that we better do that right from day one. They can report no craving, but we're using an objective scale, identifying whether they're having any craving. If so, how much. We're following that in the person who is being treated for depression and vice versa. So we have scales of depression and scales of craving on every one of the individuals. Because one of the research questions would be, are the people suffering from depression with craving, are they more likely to have response in their craving than the people who don't have depression and craving? You know, those are the kinds of studies that are generated from the first simple one, yeah, and so on. Anything else before we take a quick break? James, how long should the break be? Okay, great, good. Thank you, everybody.